everyone. I'm Prutha Pathak, PGY1 Internal Medicine at North Alabama Medical Center in Florence, Alabama. Today, I'm talking about a very interesting case of multi-organ sarcoidosis. So as we know, sarcoidosis is a multi-system granulomatous disorder of unknown etiology. The pathognomonic findings are non-caseating granulomas. And predominantly affected organs are lungs, 95%, skin, 15%, and heart are quite rarely involved at 0.5 and 2.3% respectively. This case is really unique in that there are practically no case reports I found in a lit review which had involvement of skin, bone, and heart. So the case presentation is quite complex and over a long period in time. So this is a 63-year-old Caucasian woman. She initially presented in 2017 with cutaneous skin lesions. They were erythematous and non-itchy and refractory to topical steroids. A biopsy revealed non-caseating granulomas. After a while, the patient was lost to follow-up, and she presented again in 2019 with symptoms of TIA. She said that she was experiencing dizziness and tingling affecting the right upper extremity. She was admitted, and as part of her TIA workup, we got an MRI brain. It was difficult to confirm if the TIA was due to sarcoidosis or not with a history of cutaneous sarcoid, but that was on the differential. And we ordered a biopsy of the skull. And as you can see here, there was granulomatous inflammation of the skull up to the meninges. And you can see it's a 4.8 by 1.2 by 4.9 mm lesion, which is involving the left frontal skull bone and some meningeal involvement. In 2023, she presented with syncope at rest, and she stated that she was passing out without any warning symptoms, and she was spontaneously regaining consciousness. After two of such episodes, cardiology was consulted, and after two episodes, cardiology recommended a cardiac monitor. After the cardiac monitor was set up, a third-degree AV block was detected, and a subsequent cardiac MRI was ordered. On the MRI, it was confirmed that she had multifocal areas of late gadolinium enhancement, and the MRI confirmed cardiac sarcoidosis. So eventually she was placed on a dual chamber pacemaker. So this is an extremely interesting case in that the patient has had a very prolonged course of the same illness presenting in different organs. And the take-home points from this patient is that we need to think about conducting a detailed history and physical exam, including an ophthalmic exam for all our patients suspected of sarcoidosis. And that is because ophthalmic exams will reveal the episcleritis of sarcoidosis. A chest X-ray and pulmonary function test, of course, remain the cornerstone for the hyaluronic lymphadenopathy of pulmonary sarcoidosis, and CBC and BMP will demonstrate the electrolyte abnormalities, especially the hypercalcemia of sarcoidosis because of 1-alpha hydroxylase. So pulmonary imaging continues to have a central role in the diagnosis of sarcoidosis, like we've mentioned. And at the time of presentation, when a patient presents with extrapulmonary sarcoidosis, it requires a high amount of suspicion for timely diagnosis of cardiac sarcoidosis because it can lead to dangerous blocks. One of the things that I think we can keep in mind or have clinical consideration for is all our patients who have sorry, there's somebody at the door. All our patients who have extra cardiac sarcoidosis should have a high suspicion for cardiac sarcoidosis because, like I said, patients can present with dangerous heart blocks. Thank you.
All right. So if you had one recommendation for cardiac screening for sarcoidosis patients, is there anything you would recommend or suggest?
I think it would be a cardiac MRI.
Got it.
Because it would be the most definitive diagnostic test with gadolinium enhancement, and that would confirm the diagnosis.
Got it. Okay. All right. Well, thank you very much.
Thank you. I appreciate it.